Hello everybody, I'm Bruno Fattizzo, a consultant hematologist from the Policlinico Hospital in Milan, Italy, and I'm very happy to join the program for the IHA Awareness Day in this year 2026. My idea today is to share with you the news that have been reported at the last meeting of the American Society of Hematologists, which is for us as hematologists one important point for update and to understand what's going on in the field of autoimmune hemolytic anemias. So we all know that autoimmune hemolytic anemias are rare conditions, and I like to talk as plural because there are different forms of autoimmune hemolytic anemia. So we need to correctly identify each form to treat them at the best of our ability. We know that it's a rare disease with an incidence of about one patient every 100,000 people per year, and that we have two main forms: the warm autoimmune hemolytic anemia, driven by IgG autoantibodies, and the cold agglutinin disease, which is driven by IgM antibodies in most of the times. The pathogenesis is complex because, of course, there are these autoantibodies that would attach to the surface of the red cells and destroy them in the spleen for IgG, or through the activation of the complement cascade and in the liver for IgM. But there are even other actors in the pathogenesis of the disease, including the bone marrow, which has to reconstitute the destroyed red cells by increasing the number of circulating reticulocytes. Once we see that there are hemolytic markers alterations in this disease, like LDH, bilirubin, consumption of aptoglobin, then we need to perform the direct antiglobulin test, or direct Coombs test, which is the test able to differentiate the various forms of autoimmune hemolytic anemia and to establish the final diagnosis. With this test, we take the red blood cells of the patient and we look on the surface of these cells whether there are these autoantibodies, IgG, IgM, complement fractions, attached. Once we establish the diagnosis, we need to perform a further workup with abdomen ultrasound, viral serologies, etc., and in some cases even bone marrow evaluation to exclude the concomitant presence of other disorders like lymphomas, autoimmune disease, etc., that may require additional treatment. Last ASH meeting, there were two very nice presentations in an educational session, one on warm autoimmune hemolytic anemia by Dr. Vilma Barcellini, and another one from Dr. Sigbjørn Berentsen on cold type autoimmune hemolytic anemia. In particular, Dr. Vilma Barcellini reminded us that warm autoimmune hemolytic anemias are mainly due to IgG autoantibodies that react with the red blood cells at 37 degrees, so a high temperature. That's why we call them warm autoantibodies. The direct antiglobulin test is positive for IgG, and in some patients for IgG plus complement. In this disease, the main mechanism of the disease is the destruction of the red blood cells after they are opsonized by the IgG autoantibodies and destroyed within the spleen. In some cases, complement positivity may be detected because if we have several IgG or very avid IgG, they can be able to activate complement, and these cases are even more severe than the others. Dr. Barcellini reminded us that the algorithm of treatment of warm autoimmune hemolytic anemia starts with steroids. We may add intravenous immunoglobulin in case of refractoriness to steroids after 5 to 7 days of treatment. Otherwise, we keep on with steroids with about 80% of efficacy with a full dose for 3-4 weeks, followed by a slow tapering in about 4 to 6 months. Then, if a patient relapses, we may offer rituximab. Rituximab, as of today, is the best choice for second option, second-line treatment. It offers a response rate of 70 to 80% of patients. And also, we need to wait for this response because sometimes it takes 1, 2, 3 months to get the best from rituximab treatment. If the patient relapses once again, then we should aim to candidate the patient to a clinical trial, because clinical trials represent today the main opportunities for minimizing toxicity and improving efficacy. If at least 1 year and a half, 2 years have passed since the previous rituximab, we may consider to retreat the patient again with rituximab if a prior response was observed. If the patient is not candidate to clinical trial, we may consider splenectomy in young patients or other immunosuppressants like mycophenolate or cyclosporine. Also, plasma cells inhibitors like bortezomib or daratumumab, that are therapies developed for multiple myeloma, may be considered but are off-label treatments. Responses have been reported in about half of the patients treated with these drugs. Then Dr. Berensen talked us about cold agglutinin disease. Here the mechanism is completely different because you have these IgM that are pentameric, so are like the fingers of a hand. So we have 5 different possibilities of attaching to erythrocytes. So the IgM can attach at the same time to many erythrocytes and form what we call agglutinates. These agglutinates may be hemolyzed through the activation of the complement cascade. So we have complement-induced hemolysis, but also these autoantibodies and these agglutinates may occlude the small vessels, particularly in the fingers of the hands and foot, and that's because those parts of the body are those exposed to the lowest temperature in our body. So for these patients, first we tell the patient to keep warm, to avoid exposure to cold temperatures. But we also need to consider that if the patient has a significant anemia with less than 10 grams per deciliter of hemoglobin, the patient may need treatment for reducing the number of these autoantibodies. And also, we are able today to inhibit the complement cascade in these forms, and I will show you how. So the important thing about the diagnosis of cold agglutinin disease is that we have the direct antiglobulin test positive for complement, more rarely for IgM, and we also have the agglutinates in the peripheral blood. But also we want to look at the serum of the patients to detect these circulating IgM, the so-called cold agglutinins. Then we want to evaluate the bone marrow in these patients because in more than 80% of cases there would be an infiltrate of lymphocytes. These lymphocytes are the cells that produce the autoantibody. So we need to look to these cells to see how many cells we have in the bone marrow, because this is exactly the source of the production of the autoantibody. And it is important to distinguish the cold agglutinin disease for other infiltrations by, for instance, lymphomas, which is rare but may occur. Treatment of cold agglutinin disease is with the rituximab as frontline in many cases because it is not effective to treat a patient with high-dose steroids. It doesn't induce remission. It may, let's say, ameliorate the picture, but once you start tapering, the anemia and hemolysis would flare again. So it is very important to establish rituximab treatment as soon as possible in these patients. And if rituximab is not effective, or the patient relapses, or if the rituximab is not available in the country, not reimbursed, we have now another treatment for these patients, which is sutimlimab. Sutimlimab is an intravenous drug that represents the first complement inhibitor licensed for treatment of cold agglutinin disease. In this phase 3 trial, patients were treated with sutimlimab or placebo and randomized at baseline. As you can see here in the graph, those patients represented by the black line, so those treated with sutimlimab, had a clear and quick improvement of hemoglobin levels, while those patients randomized to placebo remained stable at around 8 grams per deciliter hemoglobin level. Once even those patients on placebo were allowed to switch back to sutimlimab, then they obtained the same improvement and hemoglobin peaked at around 11 to 12 grams per deciliter. Also, if you look to the graph on the right, patients treated with sutimlimab had a very quick decrease of bilirubin levels, with normalization of bilirubin levels, indicating that the drug is effective on complement-mediated hemolysis. However, sutimlimab does not eliminate the cold agglutinin, the IgM, so the patient may still experience the circulatory symptoms like bluish of fingers, nose, etc. once exposed to cold temperature. Also, if we stop treatment with sutimlimab, hemolysis would flare in most of the patients. And again, this is important to know because it means that this treatment is proposed as a long-term treatment rather than a single course treatment as we do with rituximab. But the drug has been now approved by FDA, by EMA, and is available in many countries through with high costs. Dr. Berentzen showed his algorithm for the treatment of CAD, starting with watch and wait for those patients with more than 10 grams per deciliter hemoglobin, keep warm and take folic acid. If you have hemoglobin lower than 10 or disabling circulatory symptoms, then treat the patients first with rituximab or with sutimlimab if rituximab is not available or has failed. But still, as you can see, the algorithm needs further revision, so it is not so easy to understand, and we still need to focus and work on them as a scientific community. What's new from the ASH? I would say that the most new drug that has been reported at ASH is risabrutinib, which is, I always tell to the patients that it is like an oral rituximab, because this drug is able to inhibit the B cells that are the source of production of the autoantibodies. Risabrutinib is an oral drug given orally twice a day, and it has been studied in a phase 2 trial, open label trial, and at the last ASH we reported the results of the risabrutinib phase 2 study at 74 weeks of follow-up. Interestingly, as you can see in this very difficult picture, risabrutinib is effective on B cells, but it may also be effective on other mechanisms of the disease, including the activity of the macrophages, that are the cells that we have in the spleen and in the liver that are responsible for phagocytosis of the red blood cells. So it has possibly multiple mechanisms of action. In this trial, 22 patients were treated, 22 patients with warm autoimmune hemolytic anemia, and 1 patient with cold agglutinin disease, which was erroneously enrolled. However, he responded, so he was allowed to be treated in the trial. So what do we know from this? We know that most of these patients had a refractory relapse in disease. Most of them had received more than 3 prior therapy lines, including steroids, rituximab, immunosuppressants, and 2 patients had already been splenectomized. In the first part of the trial, about 65% of patients experienced an improvement in hemoglobin level. And you may see here that the curve in this graph, the curve of hemoglobin, goes up, even if very slowly. It goes up and peaks at around 11.5, 12 grams per deciliter. So what we observed was that baseline hemoglobin was 8.2, and at week 74, hemoglobin level were around 11.6. And hemolytic markers, LDH, reticulocytes, and total bilirubin decreased. So we had a hematologic improvement, but we also had an improvement of patient-reported outcomes, because the FACIT-Fatigue score, which is a score derived from a survey where we ask to the patients, how are you feeling in your daily activities, etc., to try and understand what is the energy level in the patient. And this score markedly improved from the baseline while on treatment with risabrutinib. This is an important thing. Concerning the adverse events, the drug had a favorable toxicity profile, but diarrhea was the most commonly reported adverse event. So we need to educate the patient about the possibility of experiencing diarrhea and the need of taking probiotics, etc. Generally, this side effect would resolve within the first 2-3 weeks of treatment. And importantly, the phase 3 trial is ongoing at the moment. So if you are patients or relatives or doctors who see patients with autoimmune hemolytic anemia, consider to enroll your patients in this clinical trial, because this is an opportunity for treating well the disease. And concerning cold agglutinin disease, there were no news, but some real-world data. These are real-world data from all over the world of more than 50 patients treated with sutimlimab, the complement inhibitor, in the real world. Again, these patients were mainly pre-treated patients with a median of 3 lines of therapy before getting into sutimlimab. About 20% of patients had already experienced infectious complications or thrombotic events. This is important to consider because in our disease, the main complications is really thrombosis and infections. And this is what we want to prevent in the clinical practice. In this study, even in the real world, we had an improvement from baseline in hemoglobin levels of more than 2 grams per deciliter, which was maintained throughout the follow-up and increased to 3 grams per deciliter at 8 weeks. And response rates exceeded 70% at all time points. So sutimlimab confirmed to be very effective even in the real world. Considering safety, in the real world, we observed much more infections as compared to the clinical trials, and this is because, of course, we did treat patients with prior immunosuppressive therapy, and this has to be taken into account when candidating a patient to a complement inhibitor. Of course, these patients were vaccinated against capsulated bacteria, Haemophilus, meningococcal, pneumococcal, but vaccination is not enough. You need to educate and to also establish anti-infective prophylaxis in those frail patients. So we concluded that sutimlimab is effective in more than 70% of patients, even in the real world, but we need to be aware about the risk of infections in these patients. On the other side, we didn't observe an excess of thrombosis. So it seems that by controlling hemolysis with sutimlimab, we may have a coverage for thrombosis. And the final novelty I would like to share with you from the last ASH meeting is the era of the so-called CAR T cells. CAR T cells are T cells, so T lymphocytes, that may be taken from the patients or from donors. If they are from the patients, we call them autologous T cells. If they are from the donors, we call them allogenic T cells. These T cells are engineered to recognize some antigens, some targets on other cells. In this specific case, on B cells. So instead of using a monoclonal antibody as we do with rituximab, we may use these cells to target and destroy the B cells that are the source of production of the autoantibodies. Both autologous and allogeneic CAR T cells are being investigated in warm autoimmune hemolytic anemia with the idea of destroying the B cells and eliminating the autoantibodies. Of course, this therapy may come with some toxicities, so we are at an early stage of evaluation in clinical trials, but this could be part of the future management of this disorder. And with this, I would like to conclude my topic, stating that the treatment armamentarium of both warm and cold autoimmune hemolytic anemia is largely enriching, with therapies coming from the clinical trials for both treating warm autoimmune hemolytic anemia, like risabrutinib, but we will see many others in the next meetings of the scientific societies, and also complement inhibition with sutimlimab for cold agglutinin disease establishes as a new standard of care for those patients failing rituximab. And I would like to thank all of you for the attention, and please reach out by email if you need any counseling or advice for your personal cases or your relatives or your patients. And thank you.